Thank you very much, Anne, for inviting me. I'm glad and honored to be here speaking to so many parents and professionals. Our practice at Columbia University does have a very large component of kids that are afflicted by various neuromuscular diseases, including muscular dystrophies. And I'd like to share a little bit of what we do. Next slide, please.
Here, hang on one moment.
So our objectives are to just keep pushing. You'll see the sentences come up on the slide. To define the landscape of congenital muscle disease and to look at an overview of the management options for CMD scoliosis. We want to talk about the role of non-operative therapy, the role of operative therapy, and the importance of a multidisciplinary approach and some directions of scoliosis management for the future. Next slide. And yeah, thanks. So we're talking today, and I'm not going to say much about etiology because we have much better experts on the line than me about this, the basic science of the disease. But we're going to concentrate our efforts today on looking at myopathies, the myotubular type, and they are, as most of you know, rare and characterized by hypotrophic muscle with central nuclei that resemble neonatal muscle. Next, please. The incidence is low, with 1 in 21,000 approximately, with that genetic abnormality that's disrupting the cellular structure and resulting in muscle weakness. Next. So our patients are characterized by hypotonia at birth or within the first few months of life, but it's a very heterogeneous disorder, and probably in part because of our lack of understanding of all the basic issues, basic science issues and pathophysiology. Sometimes it's accompanied by developmental delays and, of course, by gross motor delays. Cardiac pathologies and seizure disorders are not uncommon. And the immobility also leads to feeding and respiratory complications. Next. So spinal muscular atrophy is 3 or 4 times more common than CMD. Obviously a distinct and different pathology, but the spinal manifestations are similar and have helped us in our directions in terms of CMD treatment. So we have adapted the treatment we've been using for SMA to our CMD patients. Next, please. The spine deformities in scoliosis are 3-dimensional. If you think of the spine in 3-dimensional space, there's movement of the spine outward toward the back, which would be kyphosis, inward toward the belly or the lungs, which would be lordosis, and also rotation around an axis that you could put through the head and into the chair. This can lead to respiratory complications, particularly decreased vital capacity and increased respiratory complications, and what we refer to in the kind of modern pediatric orthopedic literature as thoracic insufficiency syndrome. Next, please. If we look at the incidence of scoliosis and neuromuscular diseases, you can see that in the general population without neuromuscular diseases, the incidence is about 3%. In congenital muscular dystrophies, it's about 30%. In cerebral palsy, it depends on the amount of involvement. If you look down toward the bottom of this graph to the myotubular myopathies and the Nimlin rod myopathies, you can see that the numbers really are large, in the neighborhood of 75%. Next. length. So the non-neuromuscular types of curves are, in general, are S-shaped, and involve less of the spine. In the neuromuscular patterns with low tone, generally we find these large shaped curves. Okay. And why does it matter? Well, obviously it can affect comfort in sitting and positioning. It can cause back pain. It can complicate the caretaker's jobs in doing transfers and getting the patient positioned. Skin issues can ensue with significant deformities. And very importantly, in the young and growing child, scoliosis can affect the lung development and alveolar development, alveolar growth. Next. So the rapid growth of the thorax is matched by the cardiopulmonary system. And if you look at this graph, you can see that the steep slope of alveolar growth and proliferation occurs at a very young age. And in fact, that first red line, the line on your left, is at age 2. And look at how much of the lung growth has already occurred. And as you get up to age 3 or 4, it's basically you are approaching the number of alveoli you're going to have for your entire life. So it's really important that we protect lung growth during that early period of time. And this realization is not one that we were able to take into account until fairly recently. Next. Most of the increase, as I said, occurs by age 4. And basically, lung growth is complete at about age 8. Not the size of the lung, but the number of actual alveoli, air sacs, in the lung. Next. The patients with spine deformity, there are decreased numbers of alveoli for a given lung volume, and this kind of restriction leads to problems as age and size of the patient increase. The severity of the lung disease is dependent on the age of onset and severity of scoliosis. On the right-hand side of the slide, you can see the chest wall circumference from fetus to adult. And if you look at that, the amount of size increase between 3 years and adult, it just about doubles in size. So there's an important, another very important period of time where we need to protect growth and to do what we can to affect a good, well-shaped chest wall. Next, please. So I want to mention thoracic insufficiency syndrome because this is defined as the inability of the thorax to support normal respiration or lung growth. So primary thoracic insufficiency syndrome is a primary chest wall disorder. Secondary TIS is a chest wall disorder such as scoliosis due to neuromuscular conditions that affects respiratory function. And acquired is that may be caused by our surgery or by other operations on the chest wall. Next. So to get our kids treated, we do need this multidisciplinary approach, and we need to include all the parameters of care for our children, including the nutrition, any cardiac issues, of course, and all the doctors that impact their care need to be involved in the treatment of the scoliosis as well. Next. So non-operative treatment options consist of bracing and, of course, the manipulative therapies, physical therapy, occupational therapy, and ambulatory aids, positioning devices, such as seating devices, wheelchairs, etc. Next, please. There's the evidence on bracing is somewhat controversial. We certainly want to avoid surgery as much as we can and for as long as we can. And we know that that surgery is more complicated in the younger child, and that we would therefore want to try to lengthen the time before surgery is indicated. but there's really a paucity of data on how much it helps or how little it helps, particularly in the low-tone kids with congenital muscular dystrophies. In the high-tone kids, there's data suggesting that if you use surgery as an outcome measure, that bracing doesn't really affect that particular outcome. However, bracing can be a real boon in the child who can tolerate it for sitting posture and for perhaps controlling and delaying the need for other more radical interventions. Next, please. So one study looked at 90 patients with neuromuscular scoliosis, and 28% of the patients looked at in that particular study progressed less than 10 degrees a year. Another study followed 20 brace patients for a longer period of time and found no benefit after 5 years of follow-up. So these studies appear to be contradictory, but they probably aren't. What we're looking at is the first study had a shorter follow-up period in somewhat younger children. The second study was a longer follow-up period in somewhat older children. And it kind of points to what I've said. We can use bracing as a helpful adjunct to therapy, but we shouldn't look at it and it's not unlikely that it won't be the definitive treatment. Next. Casting is something else that we have that we employ, and the advantage of casting over bracing is that we get the child has to be asleep for positioning in the cast. We get a little more pressure and correction, and then the disadvantage, of course, is it requires general anesthesia and trips back and forth to the operating room. But for some particular kids, it can be very helpful. And we have had used this in our neuromuscular patients. Next.
David, can you explain what the abbreviation EOS stands for?
I apologize. EOS is early onset scoliosis. So in other words, we look at any kid with basically it's age 0 to excuse me one second. I have too many phones here. So it's these babies with scoliosis, so age 0 to age 6 or 7 is early on.
Great, thank you.
All right. In Maida's study, 100% of patients that were casted showed some correction. 35% of the patients did need fusion, yet theoretically this meant that half of those patients avoided the morbidity of surgery. This particular group of patients were not neuromuscular patients, but it just points to the fact that casting does have power to control scoliosis in some patients. Next, please. There's lack of evidence that the overall rate of surgery is changed, but does the early onset scoliosis data really apply to our congenital muscular dystrophy patients? Does it really delay surgery? Next, please. As the patient, if it does delay surgery and we're able to start treating surgically an older patient, it prevents repetitive surgeries and may help prevent repetitive surgery. Next, please. So the non-operative treatments also include physical and occupational therapy. We really encourage this in our patients to maintain flexibility and to, as best we can, to avoid contractures, to practice and encourage good sitting posture, to work on exercises that improve core strength as much as we can in these very hypotonic muscles. And we also encourage the use of standards in kids that are able to tolerate them. And of course, it's important that caretakers are educated and can help with home therapies, because there's not enough physical therapy. Particularly, I know in our neighborhood, we have a hard time getting the numbers of sessions and the times that we want for our children. Next. What role does mobility play? I think that there's a positive correlation between participation and quality of life, and that is to say participation in life. And participation is directly reliant on mobility. And interestingly, what we have found and think is that most of those limitations are due to infrastructure, not necessarily to policy or to the individual family, but due to inaccessible infrastructure. So if they don't have appropriate ramps and elevators and access and curb cuts, then you can't be compensatory. So what are the surgical indications? It's an obvious statement to say they're not set in stone, but some of the guiding principles would be a progressive deformity that's not being controlled by all the non-operative techniques, bracing and therapies, curves that are more than 40 degrees, severe deformities that are causing functional problems, painful deformities, and deformities that are causing skin and positioning issues. Next, please. So there's kind of a surgery-appropriate spot, if you will, that kind of applies to a large number of neuromuscular patients. So if you look at this this graph, you can see that there's the rising line is the increasing angle of the curvature, and the falling line, the blue line, is the decreasing vital capacity that occurs with more restrictive lung disease. And we have the age kind of across the bottom there. But the big point is that as the Cobb angle increases, the vital capacity decreases. So there's a certain point, and this graph isn't meant to precisely predict that. It's just a kind of concept, but would mean that we would want to intervene before we started really losing pulmonary function to the point to where the child would not be able to sustain normal respiration. Next, please.
David, can you explain to the participants how the Cobb angle is measured? And for participants who are not familiar with the term vital capacity, this refers to the amount of air that the lungs can basically hold, the volume of air. And that decreases as one has increasing problems with breathing and neuromuscular disease. David, if you could just explain Cobb angle to the audience.
Right. The Cobb angle, basically, the spine is, in the normal condition, our spines are straight as we look at them.
I can't find the remote control.
The angle that we measure on the X-ray allows us. It's just if you draw a line that's parallel to the top vertebra in the curve and one that's parallel to the bottom vertebra in the curve, it creates an angle. So if we were to look at a Cobb angle of 20 or 30 degrees, that would be a very small or moderate curve, not terribly important. Above the 40-degree range or so, then we start worrying about that Cobb angle causing problems for the child.
Thank you.
Next, please. So our technical goals in surgery for fusion is to stop the curve progression, to have as normal a contour of the spine as we can obtain, and to get the trunk balance, that is to say, to have the head over the pelvis in a way which allows for easy balance either in standing or sitting.
So, Mommy asked me to ask
next,
you
please.
the control for the new television in your room.
The other kind of more important thing I'm going to emphasize today is our growth strategies, and there are several of them. One is called Vector, which is the rib-based systems where we really don't touch the spine at all, or don't have to touch the spine. We can grab a rib above and either pelvis or spine below to create an internal brace that can correct the curve and to preserve the rib.
I've lost the remote control, Sophie.
We also have growing rods, which are able to are connected to the spine, and
Help me, Sophie, find it.
This spine screws are hold the individual vertebra, and then we can lengthen these rods periodically to keep the spine straight. A couple of other growing systems that are not frequently applied to kids with CMD are Shilla, which is a growth strategy that allows the spine to grow off these screws and rods that you see in this picture. When I manipulate the arrow, does it show?
I'll have to do it. I'm sorry about
that. Okay. Yeah, no, it's okay. It's all right. So, and then on the far right, there's a what we call a growth modulation system, which is staples that are put into the front of the spine to discourage growth on the convexity of the curve and encourage growth inside of the curve.
Thank you.
Next, please.
So the person who has Sophie in the background, if they could just mute their phone after finding their remote, that would be great. Thank you.
So the definitive fusion is, in this example here, is a CMD patient, is accomplished by putting many fixation points in many different vertebrae and then connecting them with rods. And in general, in kids with CMD or similar conditions, we do have to fuse to the pelvis. So if you notice, there are screws all the way down into the most bottom part of the spine and into the ilium itself. And this allows for control of the curve and balancing of the curve. Because if we don't fuse the entire spine, we end up losing control in the areas that are not fused. Next, please. So which options are best? Our considerations are age, the severity of the curve, how much lung function remains or how much has been affected, and other comorbidities, and by that we mean other diseases or problems as heart disease or kidney problems or nutrition problems. What do we know about fusing kids early? Next. So this is what we call a survivorship curve in adolescent idiopathic scoliosis. This is scoliosis that occurs in normal kids. And you can see that the green line and the yellow line pretty much coincide. So there really is no excessive death in kids who have this kind of curve. Next.
Dr. Roye, can you explain what the green and the yellow line represent?
The green line is when people die who have idiopathic scoliosis and at what age, and the yellow line is the population, normal population. So if you look at this line, the two lines coincide, so that so kids with adolescent idiopathic scoliosis do not have an increased death rate over the normal population.
Thank you.
So if you look at the juvenile onset scoliosis, now this isn't necessarily just neuromuscular, but it's just kids with early onset scoliosis. You can see that there is just a big jump that in the number of deaths that occurs at about age 40, and that's because these kids have an effect on their pulmonary system that occurred because their scoliosis started very young. And next, please. And this is and one more click on the, I think will give us what we need. Yeah. So if you look at this infantile, so this is kids who have the onset of their curves in that 0 to 3 year range, and you can see that by the time they're out at age 40, they have a death rate that's 2 times normal. So this is really important for us to pay attention to these early onset curves. Next. So early spine fusion, fusing the whole spine, is associated with bad pulmonary outcomes. In fact, in 2008, I published our own data from my own patients that I fused early in the 1980s because we had nothing else to do. And they had bad pulmonary outcomes. And so we are really against fusing kids at an early age. Next. So what does this early onset scoliosis experience tell us? It says that early fusion is just not the way to go. And we think that although these studies are really looking at all early onset curves, it does help us guide the treatment of neuromuscular scoliosis. The earlier the onset, the greater the morbidity and mortality over time, and the earlier the fusion, the greater the morbidity. And you can see why, if you look at that CT scan on the right-hand side, how the lung on the left is being pushed by the spine, which is kind of invading the chest because of the deformity. And the lung on the right is doing okay, but neither of them are normal. Next, please.
Dr. Roye, can you explain the difference between the term fusion versus scoliosis surgery that may allow for growth?
Right. I think that the kind of traditional treatment for scoliosis is fusion, which means we connect each bone to bone to bone to bone, and we make bone grow between them so that there's no movement between them, and there's also no growth at that part that's fused. So that in the non-fusion techniques, what we do is we stretch out the spine, we don't fuse anything, so that allows continued growth of the chest wall and continued growth of the spine. So that's the contrast between the two different treatment techniques. Next, please. So this is the vector technique, and where it's rib-based or spine-based, and you can see a model on the left-hand picture, and on the right you can see an X-ray of a similar system. And this is avoids fusion completely. It allows lung growth, and it is the downside of this system, like all the growing systems, is we have to repeatedly intervene. We have to go back in and lengthen, make the rod longer as the child grows. Those interventions are not, they're short, and many of them we do as outpatient, but it's still, another thing the kid has to go through. Next. Expandable rods, can also attach to the spine itself, as you see in these two pictures, and they're more rigid and are better for more rigid curves where there's not as much chest wall involvement. And frankly, we favor in kids with CMD and similar diseases where they get rib drooping to use the rib-based constructs. Next, please. And again, the downside is a repetitive lengthening. So this is a picture of a lengthening procedure in a vector. So you can see that it's relatively small. If you kind of contrast the size of the incision to the hand of the surgeon, you can see that it's not a big incision, and there's not a lot of pain. The kids would generally go back to school after a day at home resting. So but it's still a deal, and repetitive surgery is traumatic to the child. Next.
And Dr. Roye, can you explain how this photo is taken, so the position of the child to orient?
Yes, the child is oriented with head to the right and butt to the left, and so this is a vertical incision along the vector device. This is a vector that we're looking at, and so the small incision is made over a little special coupling, and we take the locking device off, and then we kind of use this tool, which is kind of like a bumper jack, and just kind of expand the rod along that line, and then we put a new locking device on, we wash it out, and we close it. Next, please. Thanks. So when is definitive fusion, as we've talked about, fusing every vertebra, when is it indicated? Well, when the patient shows up late in the natural history, so if the kid doesn't come to see us till they're 11 or 12 or 13, then we're not going to do a growing system, we're going to fuse. If the patient's near skeletal maturity and we've already been treating them, and it's time to fuse. That is near skeletal maturity, by that I mean near full growth. And then failure of a growing or chest wall system. So if we've been trying to do the growing system and it's failing, then we're forced to go to fusion. Next, please. So this is an example. This is a 12-year-old girl with congenital fiber type disproportion. She walks independently. she's fairly mature. She's already having her regular periods. Her bone age is 13. And when we first saw her, the curves were measured at 35 degrees and 44 degrees. And so our recommendation was close observation. We were concerned that any treatment would interfere with her fragile ambulatory status. We didn't want to interfere with her function. Next. And 6 months later, unfortunately, the bottom curve had gone from 40 degrees to 56 degrees. So that's 12 degrees of progression in 6 months. So that's not tenable, not sustainable. So we recommended surgery. Next. And post-op, we can see that we have her spine basically straight. And clinically, she does pitch forward somewhat, which we expect from having fused her all the way down to the pelvis, but she's pain-free and she's got great sitting posture and she's still walking. Next. This is a 1-year-old with congenital muscular dystrophy. Hypotonia was noticed at birth. The G-tube was placed for nutrition. The thoracolumbar curve was first noted at 9 months and imaged at 1 year. And that curve was measured at 27 degrees. So we recommended observation and continued physical therapy. Next. And then 18 months, 6 months later, that small curve is now 52 degrees, which you can see best on the left picture. And you can see the G-tube as well, the little image of her G-tube is there. So we recommended that it was unclear if this was a positioning artifact, but it was a definite increase. So we began bracing and we re-imaged in 2 months. Next. And 15 months later, the curve was staying steady at 55 degrees. The most recent imaging shows a worsening lumbar curve at 70 degrees. So given the age and curve progression, we recommended vector insertion. Next, please. And so this is the baby with the vector in place. And at the top of the vector is around a rib, and the bottom of the vector is on the pelvis. So we're proceeding with lengthenings and to control the curve. Next, please. So this is a 6-year-old girl with a Meriton deficient muscular dystrophy. The history includes bilateral Achilles lengthenings. In this image, the curves are small at 12 degrees and 18 degrees, and so we continued observation and therapy. Next.
Meriton deficient.
So 7-year-old, 1 year later, follow-up reveals a worsening curve. Now that the lumbar curve is 50 degrees. So we recommended, after a lot of conversation with the parents, the vector system. Next. And here she is with her vector in place. This child is not a non-ambulator, so there was no real issue about going to the pelvis for her. And this system has been working very well for her. To date, she's had 4 lengthenings and continues to do well. If you look at the space, there's a little, at the top of the vector, there's a little dark space there. That's where we slide that inside piece slides down, and that's a way we have of measuring how much length we're getting on the rod. Next, please. So this is from this mom. It says, my children developed scoliosis secondary to CMD. By approximately age 5, the scoliosis caused them to have labored breathing, loss of various function, including ability to maintain sitting balance, as well as difficulty in gaining weight. After having the vectors placed, all of these issues were significantly reversed, providing an overall improved quality of life. So, and the mom generously allowed us to show everyone pictures of her children. Next, please. So don't forget our preoperative assessment, including pulmonary assessment, which we think is critical and very difficult with our younger patients. But we're doing some innovative measurements with CT volumes, etc. But it's at least I have them seen by the pulmonologist, and we try to estimate pulmonary function. Next, please. And GI assessment, of course, to make sure that our nutritional status is favorable and will sustain the operation. Next, please. Surgical site infection is one of our great bugbears. We hate it, hate it, hate it, and so we have done, we do all kinds of things, and we're doing research and looking at how to prevent infection with antibiotic timing, dosage, coverage. We've made many changes over the last few years, and our infection rate is good, but it's still not zero, and we're battling that problem. Next. We're looking at a multi-center review now, particularly in NMD patients, neuromuscular disease patients, to see what steps are the most efficacious in preventing disease. Next. This, again, points out the importance of registries. Rare conditions like CMD have problems attracting funding and investigators. CMD, is often carried in that catch-all of the neuromuscular category. Registries are vital to obtaining much-needed aggregate data. Next, please. And there is one, of course, for CMD, and we would just, I think everyone already, in this crowd already knows about it, but we just kind of want to make sure that we want to share this effort and to lend our support to it. Next, please. What's next? Until the first half of the 20th century, CMD was uniformly fatal in childhood. Our innovative treatments have prolonged life with mechanical ventilation and gastric feeding tubes and orthopedic procedures. Next, please. I think that we want to continue looking for cures for these diseases. That's really the real treatment here. I would point to the initial reports for in the small molecule treatment of the anterior horn cell and SMA in mice is very, very encouraging and may have implications for patients in the very near future. Without a cure, though, the quality of life is the important treatment outcome. Next, please. And the quality of life includes the quality of life for the patient and the family. And our research efforts also include that. We have a new instrument which was just published called Ascend, which is valid and reliable. We're looking at further validation now for whether it is sensitive enough to reflect changes in life related to operative experiences. Next, please. So, congenital muscle disease is a heterogeneous group of disorders, and it results in low tone disease and weakness. High percentage, very high percentage, develop spine deformities at an early age, probably more or less 75% across most of the various diagnoses. The treatment of this condition is multidisciplinary, and all facets of care need to be considered. Next slide, please. So growing systems, we think, are preferable for the young child that needs surgical correction of scoliosis, and that the quality of life should be an important outcome for both providers and families, not just the measurement on the X-ray.
Sure. Yeah, if you have any, do you want us to send
So thank you very much for listening to me, and I'm happy to entertain questions.
There is again.
Great. So I just would like to summarize very quickly. We will go to a question and answer session now, and we will have both Dr. Roye answering questions as well as Dr. Karsten Bonneman and Dr. Reagan Foley. Just to give people a quick summary, Dr. Roye has generously offered to answer any follow-up questions, and we request that you post your follow-up questions on a congenital muscle disease, which includes congenital myopathy and congenital muscular dystrophy, on the Congenital Muscle Disease Facebook page, and those questions will be answered. If you are not a Facebook user and you would like to email your question, please email your question to Sarah Foy, who was really the driving force in launching this webinar series. This webinar, again, has been made possible by the Joshua Fraze Foundation, the Myotubular Trust, Cure CMD, and Kaiser SCPMG, and a webinar recording will be made available in the next 2 weeks at the following sites. That's the Joshua Fraze Foundation, the Myotubular Trust, a foundation building strength which joins us in the congenital muscle disease community that we are growing, and Cure CMD. And we will save our thank yous for the end. So what we'd like to do now is invite the audience, and if we can ask people to maybe stay on the line until 10:15 if possible, so that we can have a longer time for question and answers. So if you would like to ask a question, please state your first name and the country where you currently reside, and please do not use any last names, and we will move forward. So I turn the floor over to the audience.
Her daughter has a need.
My name is Emily. I'm from the United States. Can you guys hear me?
Yes.
Yes, I hear you well.
All right. I just have a question about mild scoliosis as far as taping and Theratalks to help support it, prevent the curve from getting worse. If you've recommended it, or if you've ever seen any success with that.
It's a very good question. There's, the kind of short answer is there's no evidence one way or the other. But the kind of more holistic answer is that I do have patients who use Theratalks or taping, and intuitively I think that anything that maintains the mobility of the spine is good.
Okay.
So I have patients who have fairly, when they're in the sitting position in the X-ray room, and you get an X-ray, their curves are in the 40s, even 50s. But when they're lying down, the curves are, 10. And so we continue following those patients. We don't necessarily operate on them because, and the way that they're kept mobile is by their non-invasive, kind of manipulative therapies. And I include Theratalks and taping as part of the manipulative spectrum. In other words, someone is kind of pushing on it and keeping the spine moving and preventing it from getting stiff or achieving a structural component.
All right. Thank you. I appreciate it.
This is Cherie in Australia. If you had a child who up until 10 years old has had a straight spine and over the last 12 months has developed quite a significant curvature and has also only uses 50% of their lung capacity for a child their height, would you expect that scoliosis would increase quite quickly, given that over the last 12 months it's just appeared and become quite significant?
There's how old is the child?
10 and a half.
Yeah. So what you're experiencing is a pattern of progression that's likely related to the late childhood, early adolescent growth spurt. And so this is, unfortunately, this is a very common pattern. So the kid had they go through childhood with either none or small curves, curves maybe in the teens or 20s or, nothing to really worry about. But then as they begin that accelerated phase of growth, they're unable, because of their weak trunk muscles, to maintain the balance of the spine, and the curves get worse. I mean, the good thing about that particular pattern is that if surgery is needed in the child over 10, you can do definitive fusion safely without interfering with lung function in most children. So that would mean that it would be less likely that the growing surgery with multiple interventions is indicated. But I would keep a very close eye on it, because this pattern is common, and those curves can be, kids can literally go from 30 degrees to 100 degrees over a period of 24 months. You have to be really on top of it.
Okay. And would, if there was a significant chest deformity on one side, like slight functioning from repeated pneumonias, would that affect the ability to be able to attach a growth rod in the spine?
No, not really. We're able to, I mean, I shouldn't say it doesn't affect it. It does affect it, but we're able to handle, even with kids with very substantial chest wall deformities, we're able to handle them surgically. And these days, we're very, very fortunate to have, you know, in our armamentarium, you know, various sizes and types of implants that allow us to take care of that. In fact, in some of the kids who have significant, for instance, who would have developed adhesions or even rib fusions because of drainage of lung abscesses and that sort of thing, we actually will operate on the chest wall itself and to expand it again when we do these definitive surgeries.
Okay. Thank you very much.
Thank you.
Hi, can you hear me?
Very well.
I actually have a couple of questions. And one of them is based on a comment that you just made about the importance of maintaining mobility of the spine and using non-invasive therapies whenever possible. So in a child who is still growing, and it has been recommended to be in a Boston brace, would 23 hours a day in that brace be contraindicated for a patient who has a neuromuscular condition? Just because of the muscle atrophy?
Yeah, this is a bit of a, I'm going to be probably stepping on some people's toes with this, but I strongly feel strongly that kids should not be in braces for 23 hours a day. There's a, in my opinion, the treatment's worse than the disease in that situation. So if you have to have the kid in the brace for 23 hours a day to control a neuromuscular curve, then you should be thinking about doing a growing rod, because it causes muscle atrophy, it causes stiffness, it actually can cause, in low-tone kids, you can get, with wearing the brace all the time, you can get changes in the shape of the chest wall. You know, in other words, the pads can actually cause deformity of the rib because they can't protect themselves against the forces that the brace is putting on them. So I would talk to your doc really hard about not doing 24-hour bracing. So in that situation, perhaps what might be more prudent would be to brace the kid in sitting, because when they're sitting, oftentimes the brace actually helps function, assuming it doesn't, you know, interfere with their breathing too much or their digestive system. And then perhaps not wear it at night when they need their sleep or strength, and breathing is more difficult. There's all kinds of different ways, and I don't mean, I'm not prescribing to you, I'm just saying that every kid with neuromuscular scoliosis needs to be looked at holistically, and a bracing regimen needs to take into account their need for exercise, mobility, and to avoid the complications of bracing that include weakness and chest wall deformity.
Sure, that makes sense. Another question I have is, how would a leg length discrepancy impact the curvature of the spine, and especially in a child who has a neuromuscular condition? It
would kind of depend on whether the kid was ambulatory or not. So in kids who are walkers, it can, and you have a leg length inequality, it can cause a pelvic obliquity. In other words, the pelvis is not level, and that can kind of create a little startup lumbar curve. So that in those situations, in kids who don't have neuromuscular disease and who have leg length inequalities of 2 centimeters or less, I don't recommend lifts because it doesn't matter. But in my neuromuscular patients, I like to keep their pelvis level, and I will recommend lifts, unless, of course, it interferes with function in some other way. But assuming that they tolerate it and it doesn't make the brace too heavy and doesn't, you know, then I would, all other things being equal, I like to keep that pelvis level in the young and growing child.
Okay. And so if the discrepancy is about a 1/2 of an inch or 1 centimeter, would you recommend doing a lift inside of the shoe or altering the bottom sole of the shoe?
If it's 1 cm, you can usually tolerate inside the shoe. Yeah. And particularly if you're using sneakers or something like that, you can usually manage to get it inside.
Would there be a special shoe that would be prescribed for the orthotic to fit inside in order for, you know, comfort and things to be maintained?
Personally, and this is totally not medical, more psychosocial, and from my experience as the father of 6 and grandfather of 12, kids want to wear regular shoes. They don't want special orthopedic shoes. They want to wear, you know, the latest, fanciest sneakers or whatever. And so I work very hard to get to work around regular shoes. And I think that that's probably better for the kid. So.
Okay, thank you.
This is Anne from the. I was wondering what % correction, if you can predict the % correction you are going to get from any technique, and how you might go about doing that when you give advice to parents in terms of expectations that they might have from the surgery.
That's an excellent question. I think that first of all, the primary goal of surgery, and let's kind of go back for a moment to fusion surgery. Like let's pretend we're dealing with a 12-year-old, and we're going to do an operation that's definitive. We're just going to do one operation to correct the scoliosis, and let's assume for a moment too that this is a CMD kid, and we're going to go to the pelvis. So my most important goal of that surgery is to control the progression of the curve, so there's no more curve progression, and to balance the spine so that his head is right over his pelvis, and so that sitting posture or standing posture is as near perfect as we can be. And I don't care as much about how much residual curvature there is, as long as we are kind of in the neighborhood of, you know, less than 40 or so. Because in other words, if we restored a straight, a balanced spine, and we have protected the chest wall in a way so that it can operate in a relatively normal fashion, then that's our goal, not so much curve correction. But then the fact is that the amount of curve correction that we get with these definitive fusions is in neuromuscular kids is usually about 50 or 60%. They're tougher than we anticipate in the adolescent idiopathic crew. We expect to get 85 or 90% correction. But again, it's the amount of correction of the curve is not really the outcome that I care about. I care about a kid who's comfortable, has, you know, very small limited residual deformity that doesn't interfere with sitting or balance, and is solidly fused so that there's no chance for progression of the curve. So that's what I talk to my parents about, not about how much correction we're going to get.
Thank you.
Hi, this is Girish from the U.S. One question, what's your opinion of the Schroth method?
Very interesting. I'm a member of a group called the Chest Wall and Spinal Deformity Study Group. And we are undertaking a multi-center study of the Schroth technique. There's already one ongoing in Canada, and I'm blocking the university, but it's, I was going to say Vancouver. It's not Vancouver. It's further east. But we're going to be, we're training our therapists, and we have, our therapists have done 2 of the 3 necessary training sessions to be certified, and we're doing a feasibility study asking our patients whether or not they will randomize to Schroth or non-Schroth, or bracing only bracing and Schroth. So we're going to be looking at it. My problem with it is that all the stuff in the literature now all the publications are basically from Schroth centers, where you could argue they're kind of it's like if a manufacturer studies their own product and they're selling it, you have to be a little suspicious about the research. But in terms of what I wouldn't be supporting this effort that we're doing, which is major. It's going to be Boston Children's, my Children's Hospital at Columbia. We have CHOP on board, and we have Los Angeles Children's on board. So I'll tell you in 3 or 4 years. in the meantime, we are using it, and I think it's an interesting technique. But keep in mind, the indication for Schroth is in adolescent idiopathic scoliosis, and it's really for kids with normal chest wall muscle and normal core muscle. So that I think its application for kids with NND, is probably limited. So that's why when I prescribe physical therapy for my neuromuscular kids, I emphasize to the therapist that I want an eclectic program. I don't want, this is not religion. There's no like orthodoxy that they need to adhere to. I want them to use a mixture of manipulative techniques and to vary it and to work as hard as they can to maintain frontal balance and motion.
Excellent. Can I have one more question?
Before you ask the question, can you, Dr. Roye, can you explain the Schroth method to those who may not know what that is?
It's not easy. And again, keep in mind, this is really made for kids who are normal, have a normal neuromuscular system. So they teach postural techniques. It's like they get the patient to be aware of their bodies and where they are in space, and to kind of self-correct their curves. And they do this through a series of exercises. Now, the real McCoy, real Schroth technique originally was in hospital, everyday physical therapy. It was an admission that went on for 6 weeks. And then after that, follow up with a very intensive exercise program. So it's really kind of the if you will, in quotes, the real thing is absolutely not applicable in the United States. There's no way I can put kids in the hospital for 6 weeks to exercise. So what we've done, what we're using is a modified technique, which is very intensive over the first 6 weeks, like 3 to 5 days a week. And then after that, follow-up therapeutic intervention with constant exercise from the time that they're first taught the exercises, and about as young as you can go is about age 9, 8 or 9. Younger than that, the kids can't really learn them. And then up until skeletal maturity. So I hope that's helpful.
That's very, thank you. So my other question was around the effect of surgery on ambulation. What do you observe in the neuromuscular kids who do have ambulation before surgery? Is it a regression after the surgery?
Yeah, you noticed I presented a patient like that in my talk, and we really delayed her surgery out of fear of causing her to get off her feet. So if you have a child with low tone and who is a marginal ambulator, or someone say who needs a little bit of equipment and some balancing help and doesn't have a lot of endurance, those kids that are marginal ambulators are at risk for losing their ambulatory skills when we do their scoliosis surgery. So I'm very forthright with the parents about this. I mean, in the end, if the kid has gone from 50 to 75 degrees, there's nothing we can do. We're really obliged to treat. But it's extremely variable, and the evidence is, this is very interesting. Recently, just in the past couple of years, there have been a couple of papers at our major spine meetings that pointed out that we were being too pessimistic about the ability for kids with low tone disease to walk after being fused to the pelvis, and that in fact most of them regain at least some ambulatory ability, even if it may be a little bit less than they had before the fusion was done. And the reason for this is that when you look at kids walk who have very weak muscles, they use a hyperlordotic stance. They create a sway back, and they use motion between the pelvis and the lower lumbar spine to achieve their walking. And so when I do that spine surgery on them, I partially correct the lumbar lordosis. It's by necessity, and the pelvis kind of tilts forward. And then that is what interferes with their walking subsequently.
Thank you.
This is Sarah. I have a couple of questions that came in through email, so I was going to put them out there, if that's okay.
That's great.
Okay, Kristen in the United States had a question about what if, by chance, the lengthening process for the vector rods was delayed due to illness? So, for example, it's been 12 months since the last lengthening in a child that's at age 8, and concerns in regards to the increase in the curve or decrease in lung function.
That's an interesting question. You know, we worry about that. We schedule our vector lengthenings at about 6 months for most kids, and once you get past a year, you worry that the vector starts acting as a tether on the chest wall, and there's a that it can actually because you can imagine if you have a fixed length device on the chest wall and the spine is growing, if you don't keep up with the growth, then it will act actually as something that could increase the curve. So I would, you know, in our hands, even if the kid is relatively is not doing particularly well and is having some respiratory issues or whatever, we will often talk with our anesthesia colleagues and figure out a way that we can get that kid into the OR and do the lengthening anyway. But after a year, I'd be a little nervous, and I'd want to try to get some more length.
Okay, that person's a little bit nervous too, and that's why they posted the question there. They're concerned.
Yeah,
so.
yeah.
I had one other question. This is from Roger in the United States in regards to 11-year-old daughter with collagen 6 myopathy with a curve over 50 degrees, scheduled to undergo the Schiller procedure in the next couple of months, and looking at how to prepare for the surgery. And one of the things, I think this actually could point to a general question, is that for people, like we know, roughly 75% of our kids are going to end up with this surgery. And so what are, I think it, from a specific question to a more general question, what are the things that we can prepare for the best surgical outcomes for our children? This particular person talked about stretching flexors, hip flexors, but and also answering in a more of a general way also for that question.
Well, I think that we'll kind of start with the questioner's comment, or question, I should say, that one of the issues with all neuromuscular scoliosis is hip flexion contractures, which are either in growing surgery or in definitive surgery can interfere with our outcomes, because the kid is using back motion to accommodate the hip flexor and contraction, and once we, contracture, and once we put the instrumentation in, then that flexion contracture becomes fixed, and it's more problematic and interferes with function. So I do think that getting kids as loose as possible prior to surgery and thinking of these mechanical issues is a great theme, and a little. I often have recommended 6 weeks or so of intensive physical therapy prior to the intervention. The other issue is to be as strong as possible and as well nourished as possible, These are all issues, and we often recommend some extra calories and extra fat and protein in the couple of months leading up to the surgery. And the other thing is that depending, if your kid has normal respiratory status, that's great, but if they don't and are on some kind of nighttime ventilatory support, or they are using need other kinds of support or have frequent respiratory complications, we want to make sure that we're working with the pulmonologist and with the parents to optimize the pulmonary part of the kid's general well-being, and that would be tweaking the nighttime ventilatory support, using the kind of typical respiratory therapy strengthening exercises and volume exercises. Those are all things that could go a long way toward helping the kid have a better outcome. The other part, of course, is the psychosocial stuff, which is so important, and especially in the older child, where you can kind of affect their expectations, and talking to other kids, I think, in general, is a very good thing, especially not just any kid, but a kid who is a good communicator and can talk about what it was like to go through the surgery in a way which would ameliorate fears, not exacerbate them.
Also, I know it's very common for kids with myopathies, congenital myopathies and congenital muscular dystrophies, to have more either osteopenia or osteoporosis. And I'm just wondering, is there any treatment in preparation for surgery that you do for those circumstances, or how do you address these bone issues?
Yeah, the bone quality is often poor, and it's a technical issue for us. We're very fortunate now that the way we do the surgery, we have so much sharing of load because we instrument almost every segment, so that we're able to safely do the surgery in kids, even kids who are very osteoporotic. An extreme example for us is that we do scoliosis surgery routinely on kids with osteogenesis imperfecta, which is not a myopathy or low tone disease. It's a disease of bone where the kids have frequent fractures and have bone that's just really, really weak. So I think that in terms of medication or treatment with the bisphosphonates and that, we don't really recommend it above and beyond what has already been recommended in a good nutritional program. Like all of our kids basically should be on vitamin D3. We should look at their calcium intake and make sure they're getting adequate amounts of calcium, 1,200, 1,400 milligrams a day. But that's not really, I don't look at that as prep for surgery. I look at that as just being good bone management, and that the kids should always be, unless there's some contraindication because of renal function or other metabolic disorders, they should be on that vitamin D3, as should you. I take 10,000 units a week.
Hello, can you hear me?
Yes.
My name is Janie, and I was wondering, as our children age and they start getting towards that pre-puberty growth spurt, if they look okay with their scoliosis, are there things we can do to prevent it, like before it gets bad, like in anticipation of scoliosis in that growth spurt?
I think we've basically kind of covered the field. I mean, I think that in kids with neuromuscular disease, when they have at age 8 or 9, 10, you start seeing, you go from a straight kid to a kid with a 20 or 25 or 30 degree curve. You are right that you should be aggressive, and that assuming there are no contraindications in the kid's overall management and well-being, bracing would be indicated even in a small curve. And along with exercise to keep the core as strong as the kid is able to have it, and some manipulation to keep that curve, to keep it soft and mobile. Even in my neuromuscular patients, if they have good nighttime pulmonary function and they are, again, no other contraindications, I also make use of bending braces, which are braces that kind of bend against that long C curve, and the brace kind of keeps them in that position at night. That kind of is like getting a few hours of physical therapy while they're in bed, stretching out the curve.
Sorry. Is there also a problem with hip extension contractures with the spinal fusion?
In general, the thing that I've experienced most are hip flexion contractures. Because most of my patients with congenital muscular dystrophy or other similar diagnoses are mainly sitters, and so that they're when they sit all the time, you tend to get hip flexion contractures. Hip extension contractures are pretty rare in my practice. If I saw that a kid did not have enough hip flexion and was using the back for to accommodate an extension contracture, that would be something which I would think about addressing prior to surgery on the back.
Okay, thank you.
You're welcome.
Hello, can you hear me?
Yes.
Yeah, hi. I have Wendy here from the UK. I have a question on a new thoracic fixation technique that I've read up about called the universal clamp. And I just wondered what your opinion might be on that technique being used in a patient with a neuromuscular disease.
We actually use them quite a bit in conjunction with hooks and screws.
Yes.
Yeah, and it was invented in France, and it's just another. There's nothing new under the sun, and this quote universal clamp is a device that has basically replaced a similar technique we've been using for many years, which was the sublaminar wires. And
right.
So I like it better because it has a broader. If you can imagine, a wire is a wire, right? And it's pretty narrow, so that you could imagine it kind of cutting through bone.
Yep.
The universal clamp is wider. It's like a tape, and it distributes forces on the lamina better, and also it's adjustable, more easily adjustable during the case. So I use them in the lumbar spine in neuromuscular cases quite a bit, and in fact, I only use it in neuromuscular disease. I don't really use it in my normal kids.
Okay.
So.
Thank you.
You're welcome.
Hi, I had a quick question. I'm Daniela from the United States. I'm CMD step 1. I had spinal fusion myself 24 years ago in South Africa. I was just wondering, I had Harrington rods. Are you no longer using those?
No, we don't use them anymore. It's of historic interest.
I'm a dinosaur.
No, you're not. No, you're not. I am, because I did hundreds of them. But it's interesting, and I just said to the previous question, there's nothing new under the sun. And basically, everything we use today is derived from Harrington's invention. So basically, we use rods, and they're not that dissimilar from the Harrington rod. We still use hooks the way that the Harrington system did. What's been added is that we use other kinds of devices, like the universal clamp that we just spoke about, and pedicle screws, which are, of course, very common. And so that what we've really added over the years is the ability to connect to many, many vertebrae, and thus we can get more of a three-dimensional improvement in the shape of the spine and chest wall. And also in patients like you who have osteopenia, osteoporosis, it gives us more fixation points, so we're less worried. We don't have to be, for instance, I'm sure that you were treated in a brace or a cast after you had your surgery. or you probably were.
I had it for 2.5 years.
Yeah.
Before surgery and 6 months after.
Yeah.
Not a big fan of the brace.
So nowadays, we do the surgery and we basically, the vast majority of our kids, we don't have to brace them or cast them. We can just let them recover without that. So, so those are the changes. But but in a sense, to say we don't use the Harrington rod is too simple a statement. It really, we're using now we're kind of on the 4th generation since the Harrington rod, but it's all been incremental and derivative of that invention.
Thank you.
I'd like to ask the 2 neurologists on the call to comment briefly on how knowing and obtaining a definitive diagnosis might help guide and frame interventions for scoliosis management in the congenital myopathies and congenital muscular dystrophies. And after we answer that question, I would like to ask Dr. Bonneman to give a brief summary to conclude this call. I appreciate that there are probably many other questions, and Dr. Roye, you have been absolutely fantastic. I invite everybody to post any further questions on the Congenital Muscle Disease Facebook site or to email them to Sarah. And with that, I would like to ask Dr. Bonneman and Dr. Foley to provide us with some insight on the importance of obtaining a diagnosis.
Dr. Foley, do you want to go first?
Oh, you can go first, Dr. Bonneman.
This is a good question. It is the management of scoliosis, as we've seen, technically applies across different diagnoses. But knowing the diagnosis actually helps us to understand somewhat more about the natural history of the condition, and therefore helps us to predict to a certain degree where the scoliosis may go and what the associated implications may be. For instance, a diagnosis of CEPN1 that was mentioned just earlier, that means to us that there will be significant scoliosis, there will be progressive scoliosis, but also that ambulation is to be expected to be maintained for many, many years. And that, of course, plays into the timing of the scoliosis, but also into the technique of scoliosis correction, with maintenance of ambulation being a major concern. For other conditions, we know that once the condition or the scoliosis goes into a progressive phase, it will continue to progress, and also that helps us in discussing the monitoring program as well as the timing of the intervention. And also other conditions, when we know the specific diagnosis, we can anticipate some of the associated problems, in particular cardiac problems as well as breathing problems. Not all of these conditions have cardiomyopathy associated with them, but the few that do, that plays a great role in planning and performing the surgery. So it does play a role, and that does help us, I think, with our planning and monitoring.
So this is Reagan Foley here. I totally agree. I think it's essential that we can, as close as possible, get to a diagnosis in order to have the team caring for the patient have the best focus looking forward. And I think Dr. Roye did a fantastic overview and underscored the importance also of the multidisciplinary team planning for surgery preoperatively, and we find that here in the UK that's essential too, as well as the team in-house in the hospital being aware of post-operative needs. As Dr. Bonneman pointed out, knowing the patient's natural history is key so that the team caring for the patient post-operatively knows their respiratory function and needs, particularly with a timing of extubation and need for often BiPAP support and even sometimes prolonged. So again, understanding that the actual natural history is key going into the surgery and post-operatively for caring.
Great. Dr. Roye, did you want to give us a couple of closing comments, and then we'll have Dr. Bonneman provide a summary?
Oh, thank you. Thank you. I think I've talked an awful lot. So, I just would again thank the organizers of this. I thought it was a wonderful thing to do, and I've enjoyed talking today. I just want to emphasize, I think if I only made one point, is that there are still areas of the world where definitive fusions are recommended for kids at 6, 7, 8. And I just would encourage families to question that advice and to think that if the child really needs intervention at that point, that some growing system would really be the right way to go, despite the difficulty. Right now, that's where we should be. So that's my kind of parting point.
Thank you, Dr. Bonneman. Would you like to provide us with a summary?
Yes, I'd like to thank Dr. Roye for a fantastic presentation and really amazing insight into this problem. I've learned a lot, certainly. I would like to just summarize in a couple of minutes the major points I think that we have learned today. We know that scoliosis is prevalent across neuromuscular disorders, but it is a particular problem in the congenital muscle disorders, and that is for a number of reasons. One is, of course, the early onset of the disease itself. Secondly, in the majority of these conditions, interestingly, the muscles along the spine, so the core muscles, are particularly affected and sometimes affected out of proportion, and therefore scoliosis becomes a problem much earlier than in other conditions. In addition, often, not universally, but frequently, the breathing muscles are affected as well. So the problems are very similar, that scoliosis can be early in life before skeletal maturity is reached, before long growth is completed, and therefore prevent the challenges that we discussed. In addition, scoliosis can be significant in congenital muscle disease in patients who are still ambulating or still walking, and maybe walking for years despite of the scoliosis. And the coexisting medical problems in congenital muscle disease include a number of severe contractures in other joints, as well as in some patients cardiomyopathies. The major questions that we touched upon that I think we answered, or Dr. Roye answered to a great extent, are, of course, the detection of the scoliosis. Being aware of the problem of scoliosis in these conditions is a prerequisite to monitoring for the occurrence of the scoliosis, the monitoring of progression of scoliosis, the ways to intervene in a scoliosis. We've heard about bracing and casting. We've heard that these are not the solutions for the scoliosis. They don't change the outcome of the scoliosis, but there can be temporizing measures. If surgery is needed, we heard about the importance of the timing of the surgery. Our goal is in age of the patient, skeletal maturity of the patient, to allow skeletal growth, to allow lung growth. It depends on the dynamic of the curve, so the rapidity of progression, as well as on the flexibility of the curve and associated comorbidities. We've heard about the available techniques of surgical intervention is needed, and the greatest advance is, of course, in systems that allow for growth of the spine and therefore also of the lung, different growing systems that were discussed, and more definitive fusion systems that allow for a continuation of ambulation. And quite importantly, we heard about the importance of preparing for the surgery from a pulmonary point of view, from a nutritional and bone health point of view, as well as from a physical therapy point of view. And I think one emphasis that came out of all of these discussions is, although this problem is universal across the congenital muscle diseases, the solutions are very individualized. So every solution has to be tailor-made for the person with a congenital muscle disease, and therefore expertise and teams to be involved in this. And I think that summarizes much of the discussion that we had. And again, I'd like to thank everyone involved in the organizers for participating in this call, and also to the families for posing such insightful questions.
So a big thanks, everybody, and we hope that you will join us in the spring for the second webinar, which will be focused on breathing management and the care of respiratory issues. And with that, we will be closing this webinar. You can post your questions as stated on the Facebook page or email Sarah, and we will look forward to receiving answers and posting the answers and provide additional information through that Facebook page.